Okay, good evening, everyone. Thank you for coming today. My name is Claire Pamantuan. I'm a second year pharmacy student and co-chair of RX Pride.
My name is Grace Singson, and I'm a first year pharmacy student and the other co-chair of RX Pride. So today we have two guest speakers.
Well, before that, I just like to. This is really exciting because this is our first LGBT cultural competency by RX Pride. We actually have guests from other graduate schools, like from medicine and OT, and we also have non-USC guests. So welcome everyone. So for those of you that don't know what RX Pride is, we just started this LGBT affinity group about 2 months ago, and it branched off of Student Diversity Committee, which was also started on October of last year. So basically, we're just trying to increase, diversity, equity, and inclusion in different minorities. So this is a really exciting year for us. Go ahead, you could introduce our guest now.
Okay, so going back, so tonight we have two guest speakers. And for the first one, it's going to be Miss Lindsay Lawrence. She's a performance improvement analyst in CAC Medicine of USC. She helps incorporate lean principles in creating patient-centered processes and pathways for inpatient terms. In addition to her performance work, Lindsay is the chair of the CAC Pride Committee, which helps design and implement strategies to foster a welcoming environment for LGBTQ patients, families, and employees. She has recently led the effort for all USC hospitals to achieve the Human Rights Campaign designation of leader in LGBTQ healthcare equality for 3 years and has provided over 550 hours of LGBTQ cultural competency training throughout the health system. I would like to introduce Ms. Lindsay Lawrence.
Of the mics. Let me make sure. Can everyone hear me? Is that need to be up a little closer? Okay. Let's see if we can put this in my pocket and I won't fall down. So, hi everyone. Now that the logistics are cleared out, so it is really, really exciting to see so many people attend this. And I was just talking earlier, I love talking to students. So I work primarily on the CAC Medicine of USC side. So that's the academic medical center, our 3 hospitals, our ambulatory clinics. So I was joking earlier, I do have a job that they pay me to do. It's the performance improvement analyst, process improvement work. But I have been working to do LGBTQ cultural competency across the USC health system for about 4 years now. And I've been speaking publicly about being a bisexual woman and doing other types of kind of LGBT 101 trainings for the past almost 20 years, which when I speak to students makes me feel very old. But I love it, and I'm so happy to be here. I feel like, is the mic picking up? I know this is being recorded. Okay, I got a thumbs up. I love it. Okay. Oh, I should have segued over to this. Okay. So what I'm going to talk about is really, I don't know where everybody is with their education and knowledge of terms and definitions. So I'll talk about sexual orientation and gender identity just to make sure we're all on the same page. Then I'll go into a little bit of information about social determinants of health and really how that impacts the healthcare experience for LGBTQ people. And then really the bulk of the presentation, the part that I love the most, is what can we actually do? What are the best practices out there to create that inclusive healthcare environment, to create a space where patients want to come and get care? So going into terms and definitions, and if at any point you have questions or need clarification or anything, just go ahead and raise your hand. We'll have time for questions at the end, but I don't want this to be like a formal, you've got to keep your hands down situation. Okay, so just baseline, right? Everybody has a sexual orientation and gender identity. This is not something that's just for members of a specific community. And the terms that you'll hear, and so I'm not going to go over a ton of terms because language is always changing, right? Like the words that I was talking about 20 years ago when I started doing this, those change. Those are not the same terms that I'm talking about today. So just understand that you want to use what the person feels comfortable with, what your patient feels comfortable with, what your colleague feels comfortable with, what your friend feels comfortable with. And the terms that people use are going to be different, right, depending on the setting. So what I'm going to use if I'm in my primary care appointment is different than what I'm going to use with my friends when we're just hanging out. So that's why I'm not going to go into a lot of specifics. I always say it's kind of like a Santa's list of terms that can be applied to people in this community. So just keeping in mind that you want to understand how somebody identifies. And sexual orientation and gender identity are not the same thing. They're not related to each other. I know it can get confusing sometimes, but that's okay. So a sexual orientation, I feel like in 2019, people are a little more familiar with the idea that people can, have different ways to love and be attracted to other people. And then someone's gender identity is really how you feel about yourself, your sense of, feeling like a woman or feeling like a man or feeling outside of those boxes, which we'll talk about. And I think, especially in a clinical practice, it's helpful to think about sexual orientation having 3 dimensions. So there's your sexual identity, and that's, the actual label that you're using to describe how you feel. So for myself, I identify as a bisexual woman, a queer woman. And then there's your sexual behavior, what you're actually doing or not doing with other people. So, you might hear bisexual and start thinking about all these myths and stereotypes, but it's like, oh, well, in my case, I've been monogamous with the same person for, it'll have to be updated to 12 years in a few months. And then, again, old. And then there's your sexual attraction. So who are you actually attracted to? Who do you fall in love with? And again, like for me, been with one person, but I have the capability to be attracted to anybody, like regardless of your bits and pieces configuration. So for a lot of people, these 3 dimensions are like a perfect circle, right? What their label is, who they're having sex with, and who they're attracted to, it all fits. But for some people, it's different. They might not want to use a specific term, or they might be doing things, but they're not attracted to the people of those genders. So just keeping in mind that it doesn't have to all be, one and the same. And then, so that's the sexual orientation part. So if anybody has any questions on that, I think, especially now in this time, learning about gender and thinking about gender identity is really important because that's not something that has been talked about a lot. So when you hear gender, when we're thinking of gender, like what comes to mind, right? So for most people, I'm like testing out this little, people think of someone's gender assignment. They think of, what's between their legs. They think about what went on somebody's birth certificate when they were born. But when you're born, you don't have a say in that, right? Like you come out, someone's looking in between your legs, they're making a designation and putting that on a birth certificate. We're not coming out and saying, oh, hello, welcome to the world. I would like to have a conversation about my gender identity, right? That takes time to develop and understand. So that is somebody's gender identity. And that's really the most important part of someone's gender, is their identity, how they feel about themselves. And it's important to note, when we're thinking about gender, a lot of people think of it in binary terms, right? And that's how I was raised. I feel like how most people were raised. Someone is a boy or a girl, a man or a woman, female or male. But the world is not binary. People are not binary. Sex and gender are not binary. So those are not the only 2 options. So even if we're thinking about somebody's assigned sex at birth, right? Somebody's birth sex, that's not binary. So somebody who's intersex, that is kind of an umbrella term to cover a lot of different types of conditions where someone just doesn't fit their reproductive anatomy, their sexual anatomy, their chromosomes, anything like that. It just doesn't fit into what we typically think of as female or male. And then if we're thinking about gender identity, somebody who's non-binary, they don't fit with the man or woman. Those don't speak to them. So this is not a new thing. This is not like a trendy, all the cool kids are doing it now. People who are intersex and non-binary have been around basically since people have been around, since all of history. And we are kind of behind the times in the United States. So there's a lot of other countries out there who actually have a legal designation for somebody. They might call it a third gender, they might call it non-binary, but there's actual legal recognition of people with those identities. And that's important for us because in California, the California Gender Recognition Act, this was passed, I want to say passed in 2017, went into effect earlier this year. And that really gives non-binary people the ability to be legally recognized. So starting last year, people who I think have more intersex conditions, they can petition the court, they can submit an application to change their sex on their birth certificate to be non-binary. Somebody who is non-binary, they identify that way, they can go to the DMV now, which is super exciting, and just submit an application. So now there's not just an F or an M option, there's now an X. And I know, and again, California was not the first state to do this. We're not the last. There's a bunch of other states that have this in progress. But I know Oregon was one of the first, and my friend was like, knock, 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 like the day it opened, like, give me that driver's license. So knowing that this is now an option and is really exciting, we know our patients are going to be bringing in documents that don't necessarily have that F or an M that we're used to in a medical setting. So we need to make sure that we have systems in place. And I'll talk a little bit about what we've done at CAC later. So then we kind of had to get talking about gender out of the way and what is gender to talk about what it means to be transgender, right? So somebody who's transgender, they just have a gender identity that's different than what somebody put on their birth certificate when they were born. So you'll hear it used as an umbrella term. Again, going back to the Santa's list of terms that are out there, it encompasses a lot of different identities that are just outside of that, male or female. You'll see it abbreviated as trans. I'll probably say it as trans just for sake of expediency. And then it's so important, just anytime you're interacting with somebody, thinking with somebody, go by what they feel, go by their gender identity. We don't do pants checks on people, to know how we interact with them. I cannot, bring up a piece of paper showing you my chromosomes. Like, that's not how we interact with people, and that's not how we self-identify. So gender identity is the most important. And of course, it's not just transgender people and everybody else, right? If you're cisgender, your gender identity and what was assigned to you at birth, they go together. So if you are someone who can look back on your birth certificate or your birth announcement, like it's a boy, it's a girl, and you're like, yeah, that still tracks. Like, congratulations, you have a new identity term, you're cisgender. So some different trans identities and some that you'll see, especially if you're looking in the literature, and I'll talk a little bit about what's in our medical record. So somebody who is a transgender woman, a trans woman, you'll see it sometimes as an M to F, like male to female trans person. Again, I think more in like the literature that's out there, not really used in communicating with people, but that is somebody who was assigned male at birth, identifies as a woman, and is going to take steps to transition and live as the woman that she is. So, of course, somebody who is a trans man, a female to male trans person, that person was, again, born, assigned female, identifies as male, identifies as a man, and is going to transition and live their male life. And then getting back to that, outside of just man or woman, male or female, people who are non-binary, they could identify as genderqueer, gender fluid, a lot of different terms. Again, they just don't feel like they fit into those boxes, right? So I was talking about, somebody transitioning and living their life as the way that they feel, and there's not just one path for a gender transition or a gender affirmation process. It's all of the things that encompass, really understanding who you are, wanting to communicate that to other people, wanting to take different steps to express that. And there are a lot of different components, which I'll talk about on the next slide. But the thing that I really want to focus on here is that I feel like when a lot of people hear about somebody who's transgender, the very first question is, oh, have they had the surgery? Whatever that means, in that person's head, because there's not just one surgery, there's a lot of different options out there. And that really places a finish line, right? Like, you have to reach this medical step, this surgical step, in order to be seen as legitimate or authentic. And that's not, number one, that's not fair. Number two, that's not the lived experience of a lot of transgender people. They might not want medical or surgical intervention. You know, they're like, look, I love my body, just how I feel does not match what's on my legal documents. So really take the step to think about it, that it's not one size fits all. There's not a finish line. There's not like one step that people need to reach. It's really what works best for the person. So when we're thinking about those different components, on the personal and social side, you know, a lot of transgender people, they'll change their name, right? Like they'll pick something that feels better to them, more authentic. They'll communicate that to other people. They'll change their clothes, you know, they'll pick things that feel better for them and express what they want to express. And then they'll communicate that to other people and ask that, you know, please use my proper name, please use my proper pronouns. And these are things that, I mean, they're free, but they can come at a personal cost, right? It can be difficult to go through that. But if we're thinking about the legal and medical side of things, that's where a lot of the institutional barriers come in. And being able to change your legal documents, you know, being able to have a passport, a driver's license, a birth certificate, all of those things that I think a lot of cisgender people take for granted, being able to, you know, have kind of a medical transition to take hormones that will better align your body to feel like how you feel inside. And then being able to have access to get various procedures done. Again, it's like Santa's list of identities, Santa's list of options out there for what people can do. But those all depend on really where you live. It depends on the laws in the city, state, country that you're in. It depends on your access to healthcare. Even if the laws are there, can you find a provider that's willing to take you on and who's knowledgeable about these things? And if you are able to find that provider, do you have access to health insurance that covers that, or are you paying everything out of pocket, which is insanely expensive? And a lot of people have to do that. So that's really why we can't place that finish line, that arbitrary designation on the legal and medical side, because it's so different depending on where you are. And then just kind of wrapping it all together, you know, the acronym of LGBTQ is just lesbian, gay, bisexual, transgender. And the Q that you're seeing more and more now is for queer. And especially when I do these for older people, like, there's always this like tension, right? Like I feel it in the room because people are like, oh, that's a bad word. You know, she just said something really negative. And yes, queer does have a very negative historical connotation. It has been used as a slur. It's still used as a slur. There are a lot of people in the community that are not comfortable with it, but others, including myself, I see it, I've said this before and it's getting kind of cheesy, but I feel like queer, it's like a hug because it encompasses so many people and like everybody's welcome in there. Because if you don't feel like you fit into these other letters, even the letters, right, can feel exclusive and feel like, oh, this is not a community I can be a part of. So that's why I like queer. But if you're uncomfortable, if people you're interacting with are uncomfortable, it can also stand for questioning. So a lot of people are like, oh, okay, I like the Q much better then. And then a lot of times now you'll see the plus, LGBTQ plus, because again, getting back to that Santa's list, it includes a lot of other identities. You'll see LGBTQIA a lot, including intersex and asexual. You'll see Two-Spirit for Native American identities. So the plus, again, it's like the hug just kind of gets bigger and bigger. But it can get confusing because these, right, like LGB, those are sexual orientation terms. And then we're switching completely to T, nothing to do with sexual orientation. But of course, the community, for a lot of historical and cultural reasons, we're all in this together. And then the Q is kind of mixed together. So I think it can get confusing for some people because you're really having to parse out, oh, is this a sexual orientation thing or is this a gender identity thing when you're especially talking about practice, like clinical practice. And before I move out of this section, just a little bit of clarification on terminology, right? Because like I was saying earlier, some of the things that I was saying 20 years ago, I wouldn't say today. And one of those is homosexual. So that's something you'll see a lot, especially if you're looking in literature, medical literature. And a lot of people are so comfortable with it, but for a lot of members of the gay community, homosexual has a very negative connotation. You know, it used to be being homosexual, being gay used to be illegal. It used to be criminalized. It used to be part of the DSM. It was a mental illness. So there are a lot of these pathological, violent connotations with it. So a lot of people are not comfortable with the word homosexual anymore. So again, just thinking of these words as always describing people. You know, you're talking about a gay person, a lesbian woman, you know, a bisexual woman, a bisexual man. You're always describing somebody. You're not talking about like a clinical diagnosis or, you know, a noun, which is weird. Like don't say like a gay. Please don't do that. You can say a lesbian. Lesbian's kind of weird, like in that way, but it's like use with caution. That's like a, you know, skills 102. The idea, you know, of somebody having a lifestyle choice or it's a preference, like, no, again, 2019, all the research out there, it's something innate inside of us. It's your orientation, your sexual orientation. Words like tranny, even like transsexual, like I was talking about earlier, that has that very surgical connotation where you have to have an intervention in order to be considered authentic. Transgenderism, like what does that even mean? Again, going back to, you're always talking about a person, so using it describing somebody. I added this one in recently because I think there's a lot of perception that, oh, okay, this is a transgender, you know, a transgender man, but he was really born a woman. Was he? He was assigned female at birth, like, but he's always been who he is. We just didn't know who he was, and maybe he didn't even know how to communicate that until later in life. So the idea of somebody being, you know, born a man or born a woman or biologically this, going back to the idea that it's, you know, there's not just two options, there's a whole spectrum out there. So using the language of, you know, somebody was assigned male at birth or assigned female. And then kind of with that, the idea of somebody going through a sex change or a sex reassignment, like, well, they're undergoing, you know, procedures to affirm their gender or to confirm their gender. And then, especially with the intersex community, you'll see or you'll hear hermaphrodite, very old, very outdated, please do not use that. And just, again, always going back to, we're always talking about people. We're not talking about, you know, things, right? So, like, moving out of that, are there any questions about the terminology clarifications before I go into social determinants?
Catch box, if you guys have any questions.
I've never seen this before. Also, I thought you said cash box, and I got really excited. I was like, wait, I have a million questions. Is there cash involved? Okay. So when we're talking about social determinants of health, I was watching this keynote speech from the IHI recently, and this really spoke to me. This idea of when we're thinking about health inequity, it really goes back to those inequities in daily life, right? The power, money, and resources. And if we want to address social determinants of health, we have to look at social inequality. Because social determinants of health, right, it's just basically all of the things that impact our lives. It's where we work, where we live, how we grow up, where we play. And what they talked about in the keynote was there's these 6 conditions of daily life that really have the biggest impact on somebody's health outcomes. So early childhood, you know, and for the LGBTQ community, are you growing up in a family who is open to someone's sexual orientation or gender identity? Are you hearing positive messages or negative messages? You know, are you in, you know, school when you're young that is an affirming place or is it a negative place? Like all of those experiences. And kind of segueing into education, you know, if you're LGBTQ, are you in a space where you're learning about your history and your community? Are you in a place that has anti-bullying, you know, procedures, policies? Do you have safe spaces, or are you getting bullied? You know, and 40% of homeless youth are LGBTQ, and a lot of them are homeless because they've been, you know, kicked out of their houses, kind of these early childhood and education, because they experienced bullying at school and they had to get out of that situation. So that has a real impact on somebody when they're young. When you get older, your condition of work, and this is not just the work atmosphere that you're in, Are you able to be yourself? Are you comfortable? Are there policies in place, procedures in place? But do you even have a job? So unemployment and poverty are a bigger issue in the LGBTQ community than for everybody else. So, if you can't even get a job and there are no federal protections protecting LGBTQ people, I grew up in Florida. I think it's still legal to fire somebody because of their sexual orientation or gender identity. California has a lot more protections on the books, but that's not the case for the rest of the country. So it really depends. And then aging. So for especially older LGBT adults, and I say LGBT because a lot of older people are not comfortable with the Q. That wanted me to move forward. They're like, stop talking. The slide. So older LGBT adults, they have higher rates of disease and disability. They're more likely to be alone and isolated. They're more likely to, or I guess less likely to have a supportive family around them. A lot of people have been disowned. They've been isolated from their family. They might not have children to help take care of them. And then they might live in communities, so kind of getting to resilience of communities. Do they live in a community that has resources available, that is affirming, again, and positive, or do they live somewhere where they can't access healthcare, where they don't have, social services that are geared towards them? And then the last one, fairness. Do we live in a society that places fairness for LGBTQ people as important? I would say no. And that has an impact, which we'll talk about. So specifically looking at healthcare discrimination, this was one of the recent studies that came out a few years ago. And for lesbian, gay, and bisexual people, over half of them reported some form of healthcare discrimination. So this ranged from, I couldn't even get in to see a doctor. I was harassed. They didn't want to touch me. They discharged me early or tried to get me out of there, all the way up to I was attacked, in the waiting room, at the ER, in the ambulance, whatever. And when we're talking about transgender people, 70% have experienced some kind of healthcare discrimination. And that is just such a huge number. And these, I'm not gonna read these word for word, but these are all real stories from real patients. And the ones at the bottom row, those are from our KEC patients. So this was almost 3 years ago, 2016, we added a question to our Press Ganey patient experience survey, which every patient gets, asking, did we respect your needs as far as your sexual orientation and gender identity? And people can rate us and give comments. And just the fact that these are in there at all, we have a lot of work to do. Because of all those social determinants I talked about and experiences that people have throughout their life and living in their communities and with their families, there are a lot of health disparities in the LGBTQ community. And again, I'm not gonna go through these line by line, but really, if you're thinking about what we have to go through, yeah, of course we're gonna have, higher rates of depression, anxiety. For transgender people, the rates of suicidal thoughts or suicide attempts is like 40% compared to less than 2% of the overall population. Higher rates of cancer. If you're not getting screened, yeah, you're gonna have higher rates of cancer. Some of it's behavioral, like for lesbian and bisexual women, for breast cancer, if they're not having children, if you're smoking more, things like that. But a lot of the cancer diagnoses are because people are not coming in and getting preventative care, and they are not getting preventative care because they can't find a provider that is competent and willing to treat them. And then I talked about the more likely to be homeless, especially for younger people. So yeah, it's basically across the board. It's like, if something can go wrong, it will go wrong. But there's nothing specific to the LGBTQ community, right? These are not things that are targeting specific populations. It's because of those social determinants. So on that note, that's always the most depressing section to go through, because it's really, and I was talking about this earlier, even if we have providers who are like, oh, number one, I never learned about this. Nobody ever taught me about this in school. When I'm talking to people on the healthcare side, they're like, again, like you said, 550 hours. And I always ask people, raise your hand, if you received specific LGBT education when you were going through school. One person has raised their hand in the 550 people that I've talked to. So people are not learning this. If they're interested in it and they go to the literature, it can be really hard to find information. You're getting more and more now, but there's a huge research gap. I did a talk for our internal medicine clinic, and one of our providers, said, yeah, I have this transgender man who has been on testosterone. He's like in his 60s maybe, so he's been on testosterone for 30, 40 years. What does that do to the cardiovascular system? What does that do to specific, not a clinician, but what are the health impacts of that? Guess what? There's nothing out there because people were not doing longitudinal studies on transgender men taking testosterone. So huge opportunity for especially students to put things into the world, but it can be really hard. So when we're thinking about cultural competency strategies, it's so important to really change the culture of healthcare. So I'm going to talk about language, kind of data, and policies. So language, I think this is such a big topic right now because people are like, okay, I'm learning these terms, I'm understanding this more, but what do I say? So one of the best things is just to really challenge your own assumptions around language and try to use as gender neutral language as possible until you know what the person prefers, right? So I was doing this to some of our front desk people, and you're trained to say, hi ma'am, how may I help you, sir? Like that's part of the culture, but if you don't know what somebody wants to be called, you could really hurt them. So just saying, how may I help you? Again, I said Florida in the South, you said yes ma'am, and you said yes sir, you got in trouble. So unlearning that, really, how can I use my language to make people feel comfortable? If you're, having a person come in for their first appointment, instead of assuming, oh, she's here for a consultation, he's here over there for a consultation, using kind of a neutral descriptor if you're having to get somebody else's attention, oh, the person with the red hair is over there waiting for their consultation. They, if nothing else, embrace the singular they. I feel like anytime this comes up, there's usually, I've gotten this before, there's people who are like, well, that's grammatically incorrect. You can't use they to refer to one person. And I mean, number one, it's like we're in healthcare, we're not editing books, but also it's more important to make people feel comfortable than to be grammatically correct, but also it is grammatically correct. So take that, everyone. It's like Merriam-Webster dictionary. Apparently Shakespeare used it 400 years ago. Like the singular they, love it, embrace it, use it, practice it. If nothing else, they. It can cover so much. So I feel like I stepped on a soapbox there for a second. I just love it. Family history. This was something that we had an issue with at Keck because our medical record did not have a way to record if somebody had two moms or two dads. And we had patients with two moms or two dads, and we had to reconfigure how we entered in our family history. So if we're asking somebody about their parents, to not assume that everybody has a mother and a father, to ask about parents and guardians, because we know family structures are very diverse. And then relationships, if you're meeting somebody for the first time, or if you're trying to develop a rapport with a patient, asking them, oh, do you have a girlfriend? Do you have a boyfriend? Are you married with a husband? To just say, oh, are you in a relationship? Do you have a significant other? Or my favorite phrase is, who do you have with you today? Because being in a healthcare setting as a patient is incredibly intimidating. It's scary. People are feeling vulnerable. So any opportunity that you have to give someone the power to tell you their relationships, to tell you who's with them, that is empowering for them. And I did this, I always feel bad, it was the CF clinic. And one of the nurses, who will go unnamed, she saw this and was like, I need to get this tattooed on my arm because I do this all the time. I put my foot in my mouth all the time. And I had a patient, and I walked in, and it was a young woman, and she was there with an older man. And I feel like people know where this is going. And she said, "Oh, is that your grandpa?" And the woman's like, "No, this is my boyfriend." If she had just asked, "Who do you have with you today?" the patient could have decided, do I feel comfortable telling this person that this is my grandpa, boyfriend, person I met in the lobby, like whoever it is. You want to let them decide what they want to tell you instead of making assumptions and kind of forcing them into a situation to explain. So yes, who do you have with you today? Covers so many things. And then also microaggressions. I love talking about microaggressions because I feel like a lot of times, especially in the social determinants of health section, people are like, "Oh, well, I would never, attack someone in a waiting room. I would never fire somebody for being gay. I would never do any of that." But microaggressions are these little things that a lot of times we don't even think about just because, we're brought up in a certain culture that can come off negative and can have these very unintentional negative impacts on somebody. And a lot of times they could be disguised as a compliment, right? So saying like, "Oh, you're too pretty to be a lesbian," or like, "Oh, I never would have known you were trans. You just like a real man," like I don't know, like Pinocchio or something, like real boy. But people think that's coming from a positive place. That's not necessarily coming from a negative place, but it puts that out there that like, oh, there's a way that I'm supposed to be. And I always tell the story because I have you can't be bisexual, you're married to a man. So I've worked at Keck for 10 years now, and I have a colleague, like we still work together. But when I met her and when I was talking to her, I don't even remember how it came out, but I said, "Oh, yeah, I'm bisexual." And she was like, "No, you're not," because she knew that I was, at the time, dating a cisgender man. And so I immediately was just kind of like, "Oh, well, I assure you I am a bisexual woman," I'm like, I'm not gonna provide a list or anything, but it's real. And she was like, "No, it's not real." So just in those 2 lines, she invalidated my entire identity, right? And we're still comfortable with each other. We get along. I was like talking to her about redecorating her new house today. But at the same time, I guarantee you she has no memory of that interaction and that conversation. And it's 10 years later, and I still think about it a lot. So it's those little things that can have an impact on somebody. And again, for me, that was one time 10 years ago. If I'm going through my whole life having people misgender me, having people not call me by the right name or use the right pronouns, if I'm constantly having to say, "Oh no, this is actually my wife, not my friend or, my sister or whatever," that adds up. And I think about it like you're wearing glasses. And I'm like, I feel like people in here, some people are wearing glasses. If you get one scratch, it's annoying, but you're fine. Like you can still see, you can still function. If you start getting more and more scratches, at some point, you can't see where you're going. You can't do anything. You can't function in the world. So these microaggressions can add up, and that's why they are a health issue, right? So if you're experiencing them often, that's gonna lead to anxiety, that's gonna lead to depression, that's gonna lead to not feeling comfortable to seek out healthcare. And then, I was talking about being misgendered or not using the right name, and that's so important because everybody has a name, right? We all have a name, we all have pronouns that we want people to use when someone's referring to us. And if you don't know, don't assume, again, going back to that gender neutral language until you can kind of figure it out. And you're not necessarily going to be able to find out from somebody's documents, right? So by looking at their chart, by looking at their driver's license or whatever, again, remember for that segment of the population who is not able to get their documents changed. And I think for transgender people, it's something like 60 to 70% have not been able to change their documents. So how do you find out someone's name and pronouns, right? So getting back to that idea of giving the power to the patient, incorporating this as a best practice where you're meeting people for the first time, you're going to be introducing yourself. So you can just say, "Hey, I'm Lindsay. I ask this of everybody, just to make sure I'm not letting anything fall through the cracks. I use she and her pronouns. What name would you like me to use? What pronouns? And I don't know, for 95% of the patients, they're going to be like, I'm sorry, what? Like, it's right there on the form that I had to fill out 80 times. But they'll just kind of like tell you and move on. For those 5% of patients who have never had a healthcare provider ask them that, how amazing. Like, they're immediately going to be like, oh my God, I can feel more comfortable with this person. I can open up more. I can come to the rest of Keck, hopefully make them feel more comfortable. But you have to practice with everybody. It can't be a situation where it's like, okay, you're cool, gotta ask, like, not sure. Because then you're using your assumptions, right? Then you're profiling. And again, going back to the idea of this is not just like something that young people are doing. We have older transgender and non-binary patients in our healthcare system. They exist in the world. You just want to be safe. You just want to make sure everybody's on the same field. So kind of moving into data, because if you're finding out this information, I mean, I'm sure you guys have heard like you can't fix it if you can't measure it or something to that extent. So thinking about what patients are having to fill out when they come into the system or when they're coming into a pharmacy. So is there a form where somebody's able to identify if they're transgender, if they're non-binary? Are they able to identify their gender identity? Do you have a space where people can just tell you, here's the name, here's the pronouns I want to use? And again, not just for transgender people, a lot of people have a nickname that's not, what's on their documents, right? So this applies to a lot more people. When we're thinking about forms that people have to fill out for a medical history or family history, do you have the ability to capture somebody's relationship status that's not just, married, single? Are they able to identify, like we talked about, parents and guardians other than just the mother-father option? And then I had talked about patient experience surveys. So just, are you asking people, are you giving them the opportunity to let you know how you're doing? When we're thinking about the electronic health record, this has been a huge issue recently, and especially, I mean, for all healthcare systems, but especially for CAC. So what we did, this went into effect last October 1st. So we didn't have the ability to record if somebody's gender identity was different from their birth sex. You could not put that in there. Now we have two options. So there's somebody's, I forget how they say it. It's kind of weird, but they're separated. And now we have non-binary for both. So when somebody's coming in with a document that's not F or M, our intake people, our admitting people, whoever, they have the ability to document that accurately, and that was not there before. And then for people who are doing more comprehensive intakes, this is not for everybody, but if you're doing a sexual history, if you're doing a social history, now there's a space where somebody's like a more detailed gender identity. So if somebody's a trans man or gender queer, or they have something else that they want to put in there, that has a space. And then for sexual orientation, we did not have that before, and now there's options in there. So again, this is possible. Have people been trained on it? Are people comfortable? Do they feel like they can have these conversations? That is a big hurdle for us, and that I think is something that we need to work on. And then just policies in general. So, when you guys are rotating through, when you're ending up at places, are you at a place that has a non-discrimination policy that includes both sexual orientation and gender identity? In California, you probably will. Like, a lot of places have updated their policies recently. We had to do that a few years ago, about 4 years ago, because we had sexual orientation, but not gender identity. So, fixed. And then, again, it's not just enough to have the policy. We had to make sure, okay, let's put it in the handbooks. Let's put it online. Let's make sure that people can find it. Restroom access. So this was something that really came out of a lot of bathroom bills that were going around the country recently, saying, oh, you have to use the bathroom based on your birth sex. I mean, it was just like, oh, you're going to put a guard at every bathroom to check? Like, this is nonsense. So California has an Equal Restroom Access Act where it says if you have a single stall restroom, essentially, it needs to have gender neutral signage on it. You can't designate it for just a woman or just a man to go in there. And then at Keck, we implemented a restroom access policy that basically just says, it's like 2 paragraphs long, you use the restroom based on your gender identity. Like nobody's gonna check any documents, harassment is not gonna be tolerated. It's not dependent on what you look like. But going back to that, you can have a policy in place, but have people been trained on it? Are people comfortable enforcing that policy? That's a big area for us. We had a situation at Verdugo where the policy was in place, but there was, I think she was a non-binary patient who, was at the hospital and then was about to leave, so went to the bathroom and was like, touching up her makeup. And so one of the guests went out to security and was like, there's a man in the woman's bathroom. So security got involved and was like, you can't be in there. And then hospital administration had to get involved. And, it was a big service recovery effort and a training opportunity for us. But if we had done more education on the front end, maybe that could have been avoided. And then just talking about patient privacy. So somebody's transgender status, somebody's sexual orientation, that is protected health information. That's PHI. So it's something that should really only be shared among the care team for the people who need to know. So if there's a situation, where somebody's gossiping about a patient's transgender status or something, or saying something negative, like that's actually a HIPAA violation. So that should be reported, that should go into the system. And then are there trainings available, reminding staff, hey, if you do need to know something, like there are situations, right? Like if you're, again, not a clinician, but like if you're putting a line in somewhere, like you kind of need to know what's going on. You tell the patient, this is why I need to know this information, this is how it's going to be used, and this is protected. So if at any point you feel that this is being used inappropriately, you can report that through the system as well. And then just overall commit to best practices, right? We're not reinventing the wheel. We're not creating anything from scratch. There's recommendations from CMS. There's recommendations from Joint Commission. There's a ton of best practice guidelines out there. That's what we've used. And really what we've used at Keck is there's the Healthcare Equality Index. And this is through the Human Rights Campaign. So it's the nation's largest LGBT civil rights organization, and they created the Healthcare Equality Index back in 2007, and we started participating in 2015, and they really look at these different areas. So, what policies do you have in place? What trainings do you have in place? What are you doing for your patients? What are you doing for your employees? And what are you doing for the community? So they do this every year. All 3 Keck Medicine hospitals have received the Leader in LGBTQ Healthcare Equality designation. And I was like, hey, I'm so excited. They haven't released the 2019 survey yet, but I feel very confident that we're gonna get that again. But there are a lot of different organizations that have participated and are considered leaders. So the report's out there, but if you're rotating through any of these organizations or working for them at any point, they should have a lot of these things in place that we've talked about. And then I always have ended with this since last May. So we got a letter from a patient at Verdugo, because I feel like a lot of times I do these and it's okay. It's like, all right, you gotta figure this out and learn this and do this and make sure you're compliant with this. And it can get very cerebral, but I always want to go back to the patient. And again, not going to read this verbatim, but we had a transgender male patient at Verdugo who had been in and out of the healthcare system, like has a seizure disorder, had really negative experiences, and started to feel afraid, right? Afraid to get care, afraid of how he was going to be treated. Came to Verdugo, had an experience enough that he wrote us a letter, to say, hey, they actually used male pronouns. Like they treated me with dignity. That's like the bare minimum, right? Like that's how all of our patients should feel. But the fact that he didn't have that in other organizations, and now he came to Keck, he came to Verdugo and said, I felt safe. Like that's why we're here. That's why we're in healthcare. And that's what we want to do, is just make everybody who comes in through our doors feel safe. So like these little changes can have a huge impact on the way that people feel and the way that they experience their health and their care. So just to wrap up, really kind of simple things. You do not have to be an expert on all of this, but just challenging your own assumptions, right? Challenging your stereotypes. Our brains are wired to use stereotypes. If you have them, that's your brain working correctly. Like, we couldn't function without categorizing people. But understanding how you categorize people and understanding how that impacts the way that you interact with people, that's something to think about on a constant basis. Using that inclusive language, using the singular they, like, practice it. It'll just get easier and better. Respecting patient privacy, of course, always. You know, making that commitment to say, hey, I can change my practice. I can ask people what pronouns to use, what name I should use, and tell them mine, right? Like, that's the polite thing to do. Just treating everybody with balance and respect. So some of the conversations that I've had with LGBTQ people is like, oh, I come out to my healthcare provider and then it's like, oh, this is fascinating. Like, again, they're being positive, but it's like, oh, you just put me into like a weird box. Just treat people like people. And then getting back to that idea of just there's constant new stuff out there. Just seek out continuous learning, seek out the research, but also participate in the research. Huge opportunity to contribute to the literature out there. So I'm like, that's the end of my talk. So if you want a copy of this presentation, I didn't know if you guys were going to send it out. You are more than welcome to email me and I'll send it. I'm, like they talked about, I'm the kind of creator and chair of Keck Pride, which is the committee kind of throughout the health system. And we're really driving a lot of this work. So if you just want to learn more, I have an email distribution list. It's like it says email Keck Pride, like it's me, you're getting me. So whichever email you choose, it comes to me. So just to kind of find out what's happening, especially on the hospital side. And then I am so excited about this because this went live on Monday. We did not have any, I know. If you Googled like Keck LGBT, you got nothing. There was no information out there. There was no way for patients to know what was available at the hospital. So now we have our own page that says, hey, we have these policies. Hey, we've got Keck Pride. Hey, we've got programs. And it's only going to get bigger and better as we add more programs and add more providers. So this is new and exciting, and I encourage all of you guys to go check it out. But I would love to answer any questions that you have at this time. I know I've been putting a lot of information out there.
I really want to throw this.
I really want someone to catch it.
Just kidding.
Ready? Hello. Hi.
We're good.
Thank you for your presentation. My name is Seda, and I was wondering what kind of recommendations you would have for, I feel so fortunate and privileged that Keck is so on the right path of doing this, but what kind of advice do you have for us who are a part of other health institutions who don't have these kinds of policies and procedures in place, and how, other than trying to use the right gender pronouns and trying to be respectful of people's identities, what else can we do on an institutional level to get that ball rolling?
I think that's such a great question, because you're right. There are things that you can do on a personal, just interaction level, but then to really make those institutional infrastructural changes, I think it just takes people speaking up. Because again, I'll say from the Keck perspective, and I was telling the story earlier, this was on no leadership's radar. This came from a student. This was a med student who said, hey, I'm going to set up a meeting with the chief medical officer and say, hey, there's this, healthcare equality index out there. Can we participate as Keck? And I just happened to see that on the calendar and basically muscled my way into that meeting. I was like, hello, I would like to participate. And then again, I was an executive assistant at that time. I had no institutional power, but I said, this is something that I'm very interested in and passionate about. Can I take that on? Can I look into best practices and bring some recommendations? And I almost guarantee that whatever leader you're talking to is going to be like, oh my God, yes, please. I don't have time to do it. And I think that there's more of a sense now that this is the right thing to do, to have in place, and especially being able to bring to say, hey, there are these resources out there. Look at all of these other, organizations that are working on this. Don't you want to be in that group? Again, I'm always like, hey guys, so UCLA has this. And our leaders are like, what? We need to change. Like, we need to beat UCLA. So I think leveraging real time. I met some of the people from UCLA and I was like, yeah, so I'm just stealing all of your ideas. And they're like, yes, please steal them. Like the better you guys do, the better we do for everybody. So I think being able to bring that competitive edge and to bring those ideas and say, here's exactly what we can do, and it's not hard to do it. It just needs somebody to take that initiative, and it doesn't have to be like a CEO or somebody like that. Thank you.
I wanted to just add, as a faculty member, that we, the faculty of USC School of Pharmacy, are energized and ready and following the students' lead in wanting to integrate diversity, equity, and inclusion into our pharmacy program. And our dean Papadopoulos, wanted to hire someone, an associate dean, assistant dean for diversity and inclusion. And so that has been assigned to Dr. Melissa Durham, and Dr. Susie Park and Dr. Durham are working together to infuse this more into our pharmacy program. And I wanted to also give a shout out to Dr. Tam Fan, who is doing a great job with our residency program, and he helped coordinate all this with our students as well. So thank you.
Yeah. Grassroots, like student-led efforts really do work, and they do have an impact. So like, take that on. Who else? You guys throwing that cash cube again?
I had a question for, there was one slide where preferred was in quotations for preferred pronouns.
Yes.
I was wondering if that's the term that, if there's a better term for that, or was it since the person did the air quotations?
Oh, yeah. So this was the microaggression slide, and I added that recently because, in the reading that I've done and the talking that I've done, preferred pronoun used to be kind of a very, like, that's what you would say, right? Like, oh, what's someone's preferred pronoun? But now I'm hearing more from the trans community, from the non-binary community, that like, that's saying, it's getting back to that idea of a preference. Like, oh, we just prefer it this way, but it could be something else. Like, no, this is actually their proper pronoun. This is their pronoun. Like, where it doesn't have to have a preferred. And having it in the quotes was kind of meant to show that there is that attitude out there of like, oh, your preferred pronoun, you know, that kind of attitude of you're forcing me to use something that I wouldn't normally use. But it's like, no, you're using what is actually the case for the person you're interacting with. So I'm glad you noticed that, number one, because I just added that. And then number two, to bring it up, because it's getting back to the idea of the language is constantly changing, you know, best practices are changing. So that was really important to catch. Thanks. Who else? Anybody? Okay. Well,
Thank you so much.
thank you, everyone. This has been amazing.
So we have another speaker. Her name is Dr. Hyde,
Steal my water.
and I'm just going to introduce her real quick. So I summarized her little bio because it's going to take probably like the whole time if I say it all. She has too many accomplishments.
Oh, I'm leaving with the mic.
Okay, so Dr. Hyde is a professor of clinical pharmacy at USC School of Pharmacy. She also holds a joint appointment, psychiatry and behavioral sciences at USC's Keck School of Medicine. She received her PharmD from the University of Nebraska and completed a residency here at USC. She also provides clinical service at LAC USC Medical Center, and she is a program director for the USC's PGY2 Psychiatric Residency Program. She's actively involved in teaching pharmacy students, medical students, allied health, and psychiatry residents in both classroom and clinical settings. She has been invited to serve as a healthcare manpower development expert for the Ministry of Health in Singapore and has served as a faculty for Tokyo College of Life Sciences. So as you could see, she's recognized nationally and internationally. And Dr. Hyde has taught over 600 APPEs during her 30 years at USC. And for those of you who doesn't know what APPEs are, it's an advanced pharmacy practice experiences for fourth-year students. So it's basically just rotations throughout the whole last year of pharmacy school. And she was named the best API preceptor for 2017, and she was awarded that 2 times, so 2017 and 2000 to 2001. And in 2014, Dr. Hyde became director of USC's Office of Continuing Professional Development. I'm almost done. And she also developed numerous continuing education programs for pharmacists, and she has over 50 publications in peer-reviewed journals, professional publications, and textbooks. As you can see, we are very lucky to have Dr. Hyde here, as well as Ms. Lindsay Lawrence. So I will give it to Dr. Hyde now.
Thank you so much, Claire and Grace and Jeremy and everyone who organized this. I'm very excited to be here. I'm very excited to present. And it is an honor to follow Lindsay's presentation, which is very high level. And I learned a lot from Lindsay when I attended her webinar a couple weeks ago. And this all started because Claire saw I had a slide in my P2 lecture on pediatric mental health about how the LGBTQ community experiences more bullying. They have more health threats. And she said, hey, we're starting this organization, RX Pride, and we would really like to have a pharmacy representative to connect pharmacy practice. And so I said, well, I don't feel like an expert in LGBTQ health, but I think I would really love to talk about it and connect my experience and to learn more about it. So that's what I'm here for today, and I've studied up on it as far as the literature, and I'm going to impart my clinical experience and with a couple of patients that I have had the pleasure and honor to work with in my practice. I work in child psych and adult psych, in inpatient and outpatient. So what can pharmacists do? So we're going to talk about discussing special considerations for the LGBTQ community across the life cycle. We're going to talk about recognizing and describing whole person care needs, because as Lindsay talked about, it's just a person is a person, no matter what their gender identity is, sexual orientation is, mental health, physical health condition. We all start as people. And we're going to apply best practices in caring for LGBTQ clients, patients in diverse pharmacy practice settings. I should say that I am a cisgender woman. I have 2 daughters, and I've learned about the LGBTQ community from my clinical practice, but also from my daughters. I attended the first Models of Pride session at USC on 2011 with my eldest daughter. It was October 15th, 2011. It was very eye-opening. I learned a lot, and my husband and I went. Our eldest daughter is bisexual, and I have a younger daughter who has best friends that have had transgender experiences in healthcare, and that I've learned about it through that as well. I just think it's always good to, we're all a product of our knowledge and experiences, so I think that it's good to share that when we are communicating with others. So really, in pharmacy school, we're more and more teaching our students to become providers of whole person care. So not just one disease state, not just diabetes, hypertension, asthma, depression, but really paying attention to the wellness of the person. And they need to be involved in directing their wellness. What is the person's health goals? So we want to engage in shared decision making and preventative health care, mind, body, spirit. Medications aren't the only way someone can achieve their health care goals. I deal a lot with individuals with depression. Would they like to solve their depression, recover from depression by participating in CBT? Or would they like a medication? Or what are the advantages of using both? So these are some of the questions that we ask our clients, our patients. And some individuals are okay to be referred to as patients. Others would rather be referred to as clients or consumers. so we can ask that question as well. And I really loved this quote from the Human Rights Campaign, where this was I think a pharmacist plays an incredibly vital role in my health care. They help me manage my health, offer a wealth of information. Walking into a pharmacy and having the people behind the counter validate my identity as a transgender man and walk me through my testosterone prescription as easily as they would penicillin makes the entire experience truly positive. And that's really what we're getting at. We're getting destigmatizing healthcare, whether it's gender identity, mental health, hormone treatments. We really want the person to feel comfortable with receiving health care from us. And the first step in that is educating ourselves as the pharmacist and becoming comfortable with the terminology, as we learned from Lindsay, also with best practices in healthcare options. So this is where I wanted Claire or Grace to help me with the catch box or the microphone. How could this pharmacy setting become more welcoming to an LGBTQ population? So raise your hand if you want this thrown to you. Okay.
I think maybe like a little sticker that has a flag. I remember when I went to Germany, I had no idea what the environment was, but when the store had a little flag on it, I was like, okay, cool. I'm protected, at least in a sense.
Wonderful. I agree with you. That's great. Who wants it next? There's many more ways. Many, many more ways that this pharmacy could become more LGBTQ welcoming. Anybody else? Yes, over here. Okay. How about, they want it on the microphone, though, for the recording, if you don't mind asking the question. Thank you.
Increased privacy, so like having some type of barrier or space that you're not exposed to just everyone and everything.
Exactly. Privacy. Privacy is so important. So more and more pharmacies are constructing private areas for consultation so that the person can feel comfortable in sharing their health information, discussing with their pharmacist. So that's kind of one of the things is a safe zone. I am an LGBT ally. And so pharmacies need to train their pharmacy technicians and pharmacists on the proper communication and use of pronouns and engaging patients and on LGBTQ health issues. And then the next was a private counseling area. But there's a few more that we've identified. Who else can come up with a few more? Yeah, anybody else too? But I know you have them, but who else? There's someone back here. Yes, oh, Samara, my mentee, fantastic. One of my mentees, yes.
Making sure to be respectful and ask for the pronouns ahead of time.
Yes, so being respectful and asking for preferred pronouns, very, very good. What else? Okay, I have a few more, so how about healthy family posters that include lesbian and gay couples with children? I mean, I think that would be really, really helpful and really help destigmatize, because oftentimes parents are bringing their kids in for immunizations in the pharmacy. It could be a same-sex couple. They might not feel comfortable if they sense some discomfort from the pharmacist or pharmacy technician who's putting them in the queue for getting their immunization. So that is another way. Anybody else? Some other ideas? Okay, I have another. A CDC's frequently asked questions poster on PrEP. So the Centers for Disease Control has come out with frequently asked questions on on PrEP, which is Truvada, that can help with prevent HIV transmission. So just kind of putting the pharmacy in the context and making it more welcoming, I think, is helpful. Now, there are health disparities for LGBTQ persons that's really well described in the Human Rights Campaign that Lindsay spoke about as well. And fortunately, she said in California, there's less of a disparity about insurance coverage, but you may be practicing in other states, you may be practicing in other services. So we want to really help patients access patient assistance programs when they can't afford medications or hormonal treatment. People with LGBTQ individuals may have more chronic health conditions. They may have more allergies, asthma, osteoarthritis, eating disorders. Even I have a derm paper that goes over skin conditions that may be more common in LGBTQ individuals. Certainly HIV, hepatitis, anxiety, depression. So we really want to help patients manage all of their chronic conditions simultaneously, because we can't just go for the ones we're most comfortable in treating. We want to really treat the whole person. We know that smoking is more common in individuals who are LGBTQ individuals. Could be also related to mood anxiety disorders. There's literature to show that people are more likely to smoke cigarettes when they have an anxiety disorder or depression. Certainly getting them into treatment can help them participate in a smoking cessation program. Applies to anybody. But we really want to ask about if the person is wants counseling on smoking cessation. We already talked about depression being more likely, but in pharmacies we can screen for depression and anxiety, usually in the Patient Health Questionnaire 9, the PHQ-9, and the GAD-7. And we can discuss depression and anxiety as not personality flaws or weaknesses, but as real conditions that are biological, that impact the brain and impact other health conditions. You get better recovery from diabetes if your depression goes down. So if you are no longer depressed, hemoglobin A1C scores go down. That's well documented in the literature. And then we really want to screen for substance use disorders, alcohol use disorders. This is drug abuse screening here, and this is brief intervention, screening and brief intervention and referral for alcohol use disorders. So we really want to learn the warning signs about suicide too. Certainly individuals with anxiety, depression, chronic health conditions, particularly chronic painful health conditions, are more likely to experience suicidal thoughts and potentially suicidal behaviors. 30% of the transgender non-binary community youth attempt suicide at least once, and 40% of the transgender non-binary adults have attempted suicide. So we really want to educate ourselves on looking for the warning signs that someone could be at risk for attempting suicide, and really connect them with healthcare professionals. We're really trying to advocate that all pharmacies have numbers to call for an LCSW to come and assess a patient that may disclose suicidality. And over at the FQHC that I worked at 6th and San Pedro, we had an LCSW to call when we suspected that the patient may have suicidal thoughts or behaviors and may even need a psychiatric hold for safety reasons. So non-conforming transgender adults report greater health disparities than gender-binary transgender peers in the U.S. So I was heartened to see that there is an LGBT health journal, and there's more and more scientific journals really focusing on LGBT health. And this was a study that looked at CDC data that's drawing from the behavioral risk factor surveillance system. And so self-reported health outcomes in gender non-conforming versus gender binary transgender adults. And then the comparison group. So there's a significant difference. People, gender non-conforming individuals had higher rates of poor to fair health, difficulty concentrating, making decisions, any kind of health limitation in any way. They reported greater health disparity. And it could be what Lindsay talked about, that they're not getting preventative care, they're not accessing care for preventative health, or feel comfortable that they're not going to be stigmatized when they go to see a primary care provider or a health care provider in their plan. Now, fortunately, pharmacists are getting more and more educated and involved in transgender health. Pharmacists in some clinics and settings are establishing new services for transgender individuals. This is AJ Patel and Hyojin Sung. They discuss alternative hormone formulations for a patient who no longer wants to use injectable hormones. So this is in Ohio, and it's featured in the American Journal of Health System Pharmacies Intersections, looking at new and innovative practices that can be adopted across the country. And then Dr. Jessica Conklin is a pharmacist who's a real dynamo, and hopefully we can get her to speak to our student body at some time. She's currently in New Mexico, but she started her own clinic. She co-created an interdisciplinary clinic. She cares for transgender and gender diverse or non-binary patients, and she's expanded it to a pharmacist-run clinic. So this PHC is a designation that means that she has prescribing privileges outside of a collaborative practice agreement. She doesn't need a collaborative practice agreement with the PHC designation. And she's a board-certified ambulatory care pharmacist. For UP1s that may not know, that's what this means. And then she's certified in providing HIV care and a certified diabetic educator, because these are all chronic health conditions that a person that a transgender individual will need more expertise with. She was invited to speak at the World Professional Association for Transgender Health and is speaking more and more at our pharmacy associations. And I think Claire has her contact information too if anyone would like to contact her. She's very enthusiastic to help. So this is a great document. It's a 120-page document, but it has such rich, wonderful information. It's standards of care for health of transsexual, transgender, and gender nonconforming people, and to promote the highest standards of care, written for interprofessional clinicians, but we can refer it to patients or clients as well so that they can learn about best practices. And 0.6% of the American population identifies as transgender. And this has been increasing, so we really need to educate ourselves as pharmacists about gender health and to become better communicators with our transgender patients. So this is the table of contents, the different areas that this WPATH document focuses on. The difference between gender nonconformity and gender dysphoria, mental health, hormone therapy, reproductive health, voice and communication therapy, surgery, post-op care, clinical outcomes. Now, many of you may be familiar with the DSM-5, and it does have a designation of gender dysphoria. But this is not utilized. I've worked in psychiatry for 30 years now, and gender dysphoria is infrequently diagnosed these days because there are many people who do not have dysphoria with their gender identity. Although it is still looked at, and we certainly want to see if there is some dysphoria associated with a person's gender identity, particularly if they're a youth and they're vulnerable and at risk for potentially bullying and some anxiety or depression or other concerns. So certainly a DSM-5 diagnosis can be stigmatizing, so that's one of the reasons why it's not done. It's not made much anymore, this type of diagnosis. And it can decrease anonymity in future care settings. So I wanted to talk about developmental issues. So I have a passion for child mental health, pediatric mental health, and I've worked at the LA County USC inpatient service for my whole time here at USC. And there are individual differences in age of awareness of gender identity. Some individuals say, I always, their birth, their assigned a gender at birth may have been one thing, but they always knew that they were a boy or a girl, even if it was against what their assigned gender was at birth. And then some are not aware of it until puberty or until a little bit later. Onset of puberty creates more questions. There's variable acceptance on LGBT issues or education in school systems. Family rejection and abandonment is a real problem. Targets of bullying, and certainly at risk for suicide. So here we have a 12-year-old assigned female, announces a male gender to family and is rejected. What are the health risks for this child and family? Anybody? Yes. Depression. Definitely depression. Yes. Anybody else? Yes. Suicide, certainly suicide. And when you are developmentally, you're 12, you see things as black and white, all good or all bad. And that's why youth are more at risk for attempting suicide than adults. So definitely. So depression, anxiety, poor school performance, drug alcohol use, suicide. And for the family, conflict, anxiety, poor communication, violence. So some kids get hit for this type of behavior, which is really horrendous. So what can be recommended? Yes. Counseling. Definitely counseling. Yes, yes. So education for youth, peer counselors. My daughters went to school in the Burbank school system, and there were suicides last year in the Burbank school system, and then they hired a mental health czar, and they're trying to rally students to really get involved in peer counselors over lunch breaks and study hall to really help, because when your peer tells you you can access a counselor, it feels a lot better than when an adult does sometimes. So support for families as well. Is hormonal therapy or surgery recommended? So this is a challenging, difficult question. It depends on the severity of dysphoria associated with sex characteristics. Chest dysphoria is an increasingly recognized issue for transgender males. Surgery is typically reserved for older adolescents and adults after a year of masculinizing hormone treatment. But Lindsay and I were discussing sometimes there are such things as puberty blockers, GRNH analogs that can give more time for the youth to make a decision and have counseling and family counseling. So there's models of transition-related care. And it used to be the gatekeeper model, and where a medical professional decides if a person meets criteria for cross-gender hormonal therapy. But it's stigmatizing, but it's still considered for underage youth. Informed consent is more progressive, and that is what is embraced by the medical community. And an individual decides if cross-gender hormonal therapy is appropriate after education on benefits and risks. And this is ideal for most. CHLA, which is affiliated with Keck Medicine of USC, it has a Center for Trans Youth Health and Development, where they offer gender-affirming medical treatment, mental health services, case management, peer support groups, access to post-exposure prophylaxis and pre-exposure prophylaxis for HIV prevention. And I've included the website here for you. And one of the things that I advocate for in high schools too is the Gay-Straight Alliance. My daughter was involved in the Gay-Straight Alliance at her high school, and it was really a wonderful experience. LGBT youth are more likely to experience victimization, as we know, and there is research to show that when a youth goes to a high school that has a Gay-Straight Alliance, that they have overall better health, better performance in school, decreased substance use disorders, less misuse of ADHD medication. So GSAs promote favorable health outcomes for youth. And it's analogous to RX Pride, actually, and KEC Pride. Forming an organization where people rally for the common good can really be helpful for all that are involved in those organizations. And then my next case here is a 52-year-old who presents to our clinic for comprehensive medication management. It's a first-time appointment. Male surname is in the chart, but the clerk pointed the person out to me, and the person really looks female. I had never seen this person before. So I was seeing this person for CMM. Hypertension, these are the diagnoses. You can read here the different labs, the different meds. So how will I greet this patient? What's the best way to greet this patient? Anybody from what you learned from Lindsay? Yes. Yes, go ahead. Microphone. Go ahead.
I would ask the patient, good morning, what is the best way for me to address you?
Excellent, excellent. I love it. Good morning. What's the best way for me to address you? That's great. I said, I'm Dr. D. I'm looking forward to working with you. And then when I got back to my private office, I said, how would you like me to refer to you? Because I did see the male surname in the chart. And I did not think that this person probably wanted to be referred to as the male surname. So in the waiting room with other people there, I introduced myself. I'm Dr. D. I'm looking forward to working with you. And then when I get back to my office, I ask about the preferred name, preferred pronouns, so that we can do that more in private. Because there could be discrimination all around, you never know. Any special health concerns here? That as a pharmacist, you're looking at these medications. Anybody? Raise your hand. Okay.
The risk of DVT because the patient is taking estrogen and they also have hypertension?
Yes, so a risk of DVT could definitely be real. And so this would need to be discussed. Any type of hormone therapy, the risks and benefits needs to be discussed. But also that the hormone is, the patient is getting the hormone from the internet, right? How do we assure purity, bioavailability, and hormones really should be pure and standardized. So getting hormones from the internet, I had questions about. So comprehensive medication management, even though you might be in a hypertension clinic, an asthma clinic, depression clinic, or mood disorder clinic, you as the pharmacist you should really look at the whole medication regimen and the whole patient and address all of the concerns. Is each medication appropriate, effective, safe? Is the patient having any trouble with it? Are they able to take it as prescribed? And then we want to assess vitals, blood pressure, assess a PHQ-9 because the person has been taking Prozac. So we want to know if depression is controlled. Are there any psychosocial issues that could contribute? And smoking drugs or alcohol. This particular person was having a trouble because they were experiencing housing insecurity, trouble with potentially getting evicted. So as the pharmacist too, we could even get social services, case management involved to help work with the patient on that. We want to really optimize hormonal therapy. In looking at the primary care note for this particular patient, I see that the primary care provider was trying to get the person's hormone therapy covered, but could not do so. So that's why the patient had to get hormones from the internet. so we can advocate for getting better coverage of hormone therapy for our patients. So I know that we wanted to leave time for questions, and probably the cases maybe inspired some questions from you. But my learning points, the points that I'd like to leave you with, are youth and families really experience gender-related health issues. They should be referred to specialty health services like the CHLA clinic for the 12-year-old that I spoke about. Certainly cross-gender hormone therapy can improve wellness. There's literature showing mood improves, overall well-being improves, and health risks can be minimized, like the VTE that Jeremy talked about, through education and monitoring. And this patient stopped smoking, adopted a healthy diet and exercise program. And so this is just something that risk to benefit needs to be weighed for each individual case. And pharmacists can improve health outcomes by creating a welcoming setting, using sensitive language, and ongoing education on health risks and solutions. So thank you all very much for participating.
Any questions?
Yes, we have a question here. Do you want to do the box? Thank you.
Hi, I'm Mina. I'm actually not a pharmacy student, so I'm not super familiar with the scope of pharmacy, but I work in occupational therapy, and I was wondering, like, the piece that you said about kind of being more inclusive by depicting, like, healthy families of, like, different people and stuff in, like, the pharmacy waiting area. That kind of reminded me of, like, the baby-friendly hospitals and, like, really emphasizing breastfeeding. And I was wondering if, like, you think there are ways to kind of make that more inclusive and less, like, ostracizing to people, like maybe two males that are going to have a baby.
Yeah, I think that's a great idea. And as an occupational therapist, I'm so glad that you thought of that and brought that to the forefront. I work with a lot of occupational therapists, and you really want to look at the whole person's lifestyle. And certainly you want to have a private room if you're going to be nursing a baby. And certainly if a pharmacy can provide that, because sometimes there's a line to get your meds or a line to get your consultation, I think that would really be great. Thank you. Anybody else? No? Okay, yeah.
I actually wanted to follow up a little bit about kind of the question that you were asking about different areas, right? So thinking about things that we've specific or traditionally gendered, so maternal care, women's health, right? So we're having a conversation right now in Keck Medicine of how do we want to provide comprehensive care for the transgender population. And right now, if you're a transgender man and you're having to go see a women's health provider, right? If you got bits, you got to get them checked. And what's that making you feel like, right? And how can we change the way that we're providing care in order to make people feel more comfortable? So getting to your example of, somebody's going to have a baby, and this actually happened to my boss. He and his husband, they adopted a child, but they were there for the birth, and they were actually the very first, it was like a New Year's baby at Verdugo Hills a few years ago. And so, they had to sensitize the staff, right? Like, hey, we're the dads. We're not just like these random people showing up for a baby's birth. And so the staff had to be trained of like, here's how you interact with these dads. Here's how we think about this. And I don't know if they did anything like with the images or the posters up on the wall, but I think it's definitely an opportunity. And it just gets back to that. Once you start thinking about it, it's like, oh yeah, we can put, a little rainbow sticker up. We could put the little human rights campaign, logo up. There's different ways that we can signify, hey, we're we're more welcoming than maybe what we've traditionally been in the past. But I also want to call out occupational therapy, because the USC occupational therapy intake form actually does have a space where people can put their gender identity, their preferred pronouns, their preferred name. I remember going there, again, as a patient. I'm a staff member, but I'm also a patient throughout Keck Medicine. And I was like, hey, what's up? So it's just that feeling of, even, again, like you were saying, as a cisgender woman, people get my pronouns right, I don't know, 99% of the time, 100% of the time, but just seeing that option there immediately made me feel more comfortable. So that's something that occupational therapy is already doing, and that the rest of USC can be doing as well.
Yeah,
I just wanted to, OT is doing it right. So.
Thank you. Jeremy.
So I'm sure this question could be like a whole other presentation, but is there a quick suggestion for healthcare professionals when interacting with patients, especially children whose parents may not be accepting of their sexual or gender identity?
So, yeah, family therapy is really, what's recommended, and it is really challenging because you have to really try to break the ice and establish an alliance with the family and understand that, culturally it might be really hard for them, and trying to really get them to recognize that, as the healthcare provider, that we understand where they're coming from too, but we also want to make sure that we are providing the best care for their child. And I think putting them together with other families that have gone through a similar conflict and come to some understanding and resolution is the most successful that I've seen. But it can be really, really difficult at first. And sometimes people are just not communicating. And so it can just take time. Sometimes the youth has to stay with a more understanding, safe family member for a while until the family gets more comfortable and therapy starts. So I think each case has to be considered on an individual basis. But yeah.
Also, I'm glad that you brought that up, because I want to say it was almost this exact question at a recent transgender health presentation that happened at Keck, where they were asking about, what if you have a youth client who's not out to their family, or you need to keep that information confidential? How do you respect their identity in the session when the parents might be there and you don't want to out them? And so it is such a tricky situation. And again, not a clinician, don't work with young people, but we were talking about, again, using as gender neutral language as possible, right? So when you're referring to the child, to not use their name, right? They might be using another name that their parents don't know about. So if the parents are in the room, don't call them, by their actual name, but the name that they like. Using gender neutral pronouns, using they if you're referring to them. And then if there's an opportunity to ask the child, to ask the young person, hey, what would make you feel the most safe in this situation? What do you want me to do? Because some young people might say, you know what, call me by, my chosen name, call me by my pronouns. I don't care what my parents think, they just have to deal with it. Others, that could lead to violence, that could lead to them getting kicked out of the house, that could lead to abuse. So the person might say, actually call me by my legal name, call me by the pronouns that they want, just because I can't get out of the situation right now. So if there's a chance to find out what would make the young person most comfortable, even if it goes against, you want to affirm their identity, but you also want to make sure that they're safe. And then if you can't do that, to just try to be as neutral as possible, I don't know, hey, you're my favorite person to come through the door today, to not avoid names, because it is really difficult with young people who don't have the same kind of agency and the same kind of access to referral services as older people.
So let's say in a situation we see some kind of hostility between the parents and the child. Is there kind of a set protocol that we need to take, or do we first need to speak to the patient first to see if they're comfortable with us following that protocol? What's the best step to take?
Well, if there's any kind of abuse situation, we would want to get the Department of Children and Family Services involved, and so if we suspect abuse, we can't send the youth home with the person who may be the abuser. So we really get social services involved to try to sort those things out. But it's really delicate, it's tricky, and our psychiatrists and child fellows get a lot of training in how to deal with that. And most of the time as a pharmacist, we don't deal with that as much, but if we're recognizing it, I would certainly then, if they're in my medication group and the child says something to me about a family member abusing them, I'm obligated to let the team know, I heard this child disclose the family members abusing them. Then they would start the process of getting social services involved. Mm-hmm. And that has happened sometimes, We've had kids that disclose gang ties, and we have to talk to the clinicians about it and things as well. So it's a delicate area, and you'll learn more about how to handle all these when you get into your clinical experience, your clinical rotations.
And I think even just from if there's not, kind of what I was hearing is there's not abuse to the reporting level, but if there's just like this conflict situation, even if there's nothing that you can do to intervene, having literature available, pamphlets, having the signage up that's saying this is a safe space, so that even the parents are coming in and saying, oh, well, I'm seeing an image of this. I saw a brochure about this. Like, maybe I want to learn more if I'm bringing my kid here. So just those almost passive ways can make a difference, and it could push the family to searching out some resources as well if you're not able to have those conversations.
Thank you so much for your questions. Unfortunately, that's all the time we have for Q&A and discussion. If you could please give a round of applause for our guest speakers. Thank you so much.